Today I'm going to be talking about high cost, high need children and young people. And first off, just a big thanks to my collaborators both at Imperial College London as well as colleagues at the Health Foundation. So to start off, a fair bit's already known about the distribution and concentration of spending in high cost, high need patients. So in England, we know that the top 5% of patients account for more than 50% of total healthcare costs, including both primary and secondary care services. And internationally, this varies between around 40% in Canada and 60% in Japan. We also know that costs are concentrated in inpatient admissions, and that this is a major driver for the difference between high cost, high need patients and all other patients. And that age, multimorbidity, and deprivation are strong drivers of being in that group, and that costs are obviously strongly associated with proximity to death. That said, less is known about children and young people. Majority of these studies have been conducted on adult populations and don't specifically examine children and young people. And there are a couple of reasons as to why we think children and young people could be potentially different. So firstly, children and young people just have different patterns of morbidity and as a result, healthcare utilization. They've got different long-term conditions and have a different need for services. Second, children are far more likely to have isolated incidents of poor health, which means that high costs are not always persistent over time, if you think about a trampolining accident and so on. And then finally, because of advances in technology and care over recent years, it means that children with complex needs are surviving for much longer than they would have previously, which is resulting in a growing cohort of children with complex needs who require sort of prolonged intensive treatment. So then the aim of this project was to describe the pattern of primary and secondary healthcare service use for children and young people and to look at the distribution and concentration of spending. So when it came down to the study, we had a sample of 300,000 patients from CPRD, which is linked to hospital episode statistics, ONS mortality, as well as IMD. It was a nationally representative sample of sort of the full population. So we then limited the sample down just to children and young people up to the age of 25, removed all deaths and deregistrations, and ended up with a final sample of around 78,000 and approximately 4,000 people that would be classified as the top 5%. And just to note that this work uses data provided by patients and collected by the NHS as part of their care and support. So in terms of our approach, the first step was to calculate the utilization of primary and secondary care services. So we did that and then estimated costs for each of these contacts based on HRG codes or PSSRU unit costs. In terms of comorbidities, we identified comorbidities in HES using ICD-10 codes, which are based on all admissions from 1 year prior to the analysis period. The high cost, high need group was defined as the top 5% of patients by cost in the 2015-2016 year. And then we carried out a descriptive analysis comparing cost and utilization across the high cost, high need group, as well as all other patients. So then moving on to some results. This graph shows the concentration of costs, and you can see that the high cost, high need group accounts for around 54% of total healthcare spending. And if you compare this to the adult population, this is slightly higher, so it's more concentrated in children and young people. What you can also see from the graph is that inpatient care seems to be the predominant driver of those costs. And I don't have this in the graph, but if you then break this down and look at mean costs per patient per annum, children and young people in the high cost group have costs that are 23 times higher than all other patients. So really a substantial difference between the mean cost per patient in that top 5% compared to all others. And then if you try to break this down further to try and understand, well, is it costs or is it utilization? You can see that utilization is higher for that high cost, high need group, but that also the cost per contact is also higher. So there's something about the utilization and severity being drivers of the healthcare cost. So then moving on to look at some demographics. This slide looks at the age and sex distribution of the high cost, high need group. So the graph shows the proportion of children and young people within each age group who fall into the high cost, high need group. I've got a dotted line across there at 5%. And if there was no relationship between age, what we'd expect is around 5% of each age group to be falling into the high cost, high need group. However, we know that this is not the case. And sort of somewhat as expected, you can see that sort of spike in under fives into the high cost, high need group as a result of preterm births. But I think what's really interesting then is for males, you've got this somewhat constant line across just under 5%, and age doesn't seem to have a major impact there. Whereas for females, you've got the slight drop, and then it sort of suddenly skyrockets from age 15 onwards. So that of females aged 20 to 24, 11% are in that high cost, high need group. And I'll come on to in a moment what some hypotheses could be around this. Obviously, one potential reason is maternity cases, but we look at comorbidities later, and there's some potential indicators there as well. Similar to the previous slide, this graph shows the proportion of children and young people within each IMD decile who fall into the high cost, high need group. Once again, I've got that dotted line across at 5%, and if there was no relationship with deprivation, we'd expect roughly 5% of each decile to be falling into that high cost, high need group. Instead, what you see is in the least deprived group, fewer than or less than 4% of that group fall into the high cost, high need group, whereas in the most deprived decile, more than 6% of children in the most deprived group fall into that high cost, high need group. And what you can see is just how, I guess, steep that gradient is. And in comparison to adults, if you carry out the same analysis, the gradient's much steeper for children and young people, which I think has just interesting demonstration of the impact of child poverty on health. Then moving on to look at some comorbidities. So just to start off, children and young people in the sort of high cost, high need group had around 50% had one or more long-term condition. Mental health, metabolic diseases, musculoskeletal, neurological diseases were the most prevalent conditions in the high cost, high need group. And sort of somewhat obviously, an increasing number of comorbidities was linked to a higher average cost per patient. As I mentioned previously, we're quite interested to see what was potentially driving that age increase. So we started looking at comorbidities by age group. And in the graph, you can see we've got mental health, metabolic, musculoskeletal, neurological by age category. And what's really fascinating is that mental health trajectory, so that just less than 40% of children and young people in a high cost, high need group have at least one diagnosis of a mental health condition. And that really sort of increases dramatically with age. I think in some respects, it's not unexpected. We'd expect mental health to increase with age, but I think the scale of that increase is really interesting. And that is one potential driver for what we're seeing in that sort of increase in females earlier on. But further work is really needed to understand that. Unfortunately, the data just got too sparse at this point, so we couldn't disaggregate it by sex as well. And then moving on to persistency. Around 30% of children and young people who were in the high cost, high need group in year one were also classified as high cost, high need in the following year. And what is quite interesting is that this is not dissimilar to the adult population. So we might have expected there to be a higher incidence of sort of isolated incidence of health it seems to be broadly consistent with the adult population, which was really interesting. And then just to summarize, so we've seen that high cost, high need children and young people account for the majority of healthcare costs within this age group of 0 to 25, and the costs are highly concentrated in inpatient settings. We've also seen that there appears to be a strong relationship between deprivation and the proportion of patients in that high cost, high need group, just highlighting the impact of child poverty. And we've also seen that the prevalence of mental health in that high cost, high need group increases dramatically with age. And further work is really needed here to understand what's going on. However, just to note, we weren't able to include all costs. So include primary and secondary care services, as well as GP prescribed drugs. But we weren't able to include community care, specialist mental health care services, which potentially makes the mental health cost even more interesting, as well as specialized drugs and any social care services. And furthermore, no attempt was made to determine whether the costs of care were appropriate for a given level of patient need. Then, just to wrap things off, I think understanding the extent to which care needs could be addressed in other settings and moving children out of hospital could not only help reduce costs, but also really improve care. Furthermore, being able to predict the future costs of children and identify future high-cost, high-need children could help target preventative services, and this is something that Dougal and Tom are looking at further. And then, just given the current pandemic, COVID's had a significant impact on the way in which people use and interact with healthcare services. And given that we know that children are high users of A&E services as well as inpatient care, I think further work is really needed to understand how COVID has influenced this high-cost, high-need group. And then finally, just to say, as I mentioned previously, that further work is needed to understand the mental health care needs of children and young people. If you have any questions, please do get in touch with us on Twitter. And once again, a big thank you to my collaborators at Imperial and colleagues at the Health Foundation. And if you're interested in looking at our code, it is available on GitHub. Thanks very much.